Yeah. So next speaker is Dr. Sanyukta Gupta. She is a consultant radiologist with us with expertise in MRI. So I have requested her to tell us that once an ultrasound has been done, when or which lesions seen on ultrasound should be further investigated.
Good evening, everyone. I'm very thankful to Dr. V.K. Kapoor, sir, for having me here. I'll be talking quickly about the CT and MRI images of common focal liver lesions. And just an overview of my lecture, we'll first talk about the CT and the MRI protocol, which is a basic necessity. If it's not a good quality scan, it's as useless as no definite diagnosis. And we'll further go for the common benign focal liver lesions, common malignant focal lesions, and a bit about LIRADS, which is the newer reporting pattern followed in a cirrhotic liver. So focal liver lesions, as my dear colleague is talked about the benign cystic solid lesions, malignant, and the rare tumors on the ultrasound. I'll just talk about the most common ones. So as far as the cystic ones, they were quite extensively talked about in the ultrasound, and I think ultrasound favors a lot more, clinches the diagnosis a lot in the cystic lesions. As far as the simple hepatic cyst, biliary hematoma, or the Caroli disease, polycystic liver disease, the ciliated foregut duplication cyst, various infective causes such as the amoebic pyogenic abscess, hydatid cyst, neoplastic, post-traumatic, miscellaneous. So I'll not be talking about these in details. We'll just see their pictures, but and some of the rare tumors, they can't be covered in a short duration. So we'll just focus so that we can gain maximum from this lecture, and we'll just focus about these few lesions, which are the solid and the malignant lesions. The commonest ones, they will cover about approximately 80% of the common liver lesions we see. So again, this looks a very exhaustive site, and if you're not a radiologist, this just baffles you up and you feel like this. So let's just see if we can do in next 15 minutes or so, can summarize the important details, and you just can get a perfect diagnosis after an imaging. So what is the CT protocol that we need to follow? Is it always a triple phase CT? We just write about a triple phase CT. So we need always a plain CT scan for sure. And this is not like always needed, it is always needed. So we need to distinguish between a fat, calcification, hemorrhage, which is more better diagnosed on a plain image. We have the early arterial phase, we have the late arterial phase, portal venous phase, and a delayed phase. So early arterial phase is usually mainly an angiographic phase, and if you have a vascular abnormality, then this is preferred. But what is actually a triple phase CCT is comprising of these three phases: late arterial, portal venous, and a delayed phase. So late arterial phase mainly enhances the lesions seen in the liver. We'll see further in our lecture. So when you see the late arterial phase, so basically the aorta has enhanced and the blood has come in the portal vein as well. So this is when you can say this is the perfect late arterial phase taken. So what happens in actually the early arterial phase, you do get the angiographic details about any aberrant vascular, about any thrombosis in the artery or something like that, but you don't know the lesion characteristics per se. So when we go for the late arterial phase, the lesion characteristics can be known very nicely. As far as the MRI protocol, we have the T1 and the T2 images. T1, especially, we have the in and out of phase. What are these images? These are basically for the intravoxal fat. So the lesions containing intravoxal fat will become black on out of phase images, and thus helps you identify the lesion characteristic. Axial T2 weighted fat sat images, this enhances the cyst and the hemangiomas. Diffusion weighted, we all know the sinister ones, the malignant ones show the diffusion restriction, as well as the inflammatory, the abscess. They also show the diffusion. So as far as the dynamic contrast enhanced MRI is considered, so it is the same as the CT protocol we follow. The subtraction images, what we see and what we call as subtraction is basically if we see any T1 hyperintense lesion, so basically the post contrast MRI taken is a T1 weighted images. So if it a T1 hyperintense lesions, we don't know it's actually per se it was a T1 hyperintense, or after in the contrast it has become enhanced. So we need to have the subtraction images for T1 bright lesions. Hepatobiliary phase happens only with the hepatocyte specific contrast. If we have taken that, we have given the patient a specific contrast, then we acquire this phase. MRCP images, obviously, when we have a biliary dilatation and we have to tell us the extension of the lesion. So a little about the hepatospecific contrast. So we have two of them, multi-hands and the EOVIST. EOVIST is not available in India. Multi-hands is what we use, and the phase is taken at about 1 to 3 hours. So the patient needs to sit for a longer time here, and it also, we do not give any other gadolinium contrast. It will acquire all the other dynamic contrast phases as well. So what is important is we have to rule out the pseudo lesions. The lesion is not in the liver, but you are characterizing it as one. So this is the most common one, as Dr. Hira also talked about this, the focal fatty infiltration. So this is nothing but a geographical area, and this is not a lesion. It is, the locations are very specific for it, near ligamentum fissure, near ligamentum venosum. So these are focal fatty infiltration, which appears hypodense on CT. Another one, which is this was a case. So this was a 30-year-old male. As we can see, this is a cirrhotic disease liver. We can see the splenomegaly, the multiple gamma antibodies, and the left lobe hypertrophy. And these are the lesions. This is a T1 weighted image showing a hypointense. This is one which is showing a hyperintense lesion. Multiple hyperintense can be seen in the liver, and we are worried about the HCC. So what happens? We have to project the patient on a triple phase MRI. And what we see on the arterial phase were these vessels at the base of the lesion. These were not any other lesion, but these were vessels which are just arterioportal shunts. This is the hepatic artery draining in portal vein, as because the hepatic vanules have been compromised by the cirrhotic liver. So what happens is the arterial phase itself clinches the diagnosis, and you are sure and makes the patient safe that it's a arterioportal shunt, and he just needs to follow up. So these were non-tumorous arterioportal shunts, and these are the commonest intrahepatic shunts. We just discussed the pathophysiology. Another pseudo lesion, very common, is the THUD, or we also call it as THID. So these are, what are these? These are basically perfusion abnormalities. Whenever a lesion is very hypervascular, or whenever there is a perfusion abnormality, for example, in a cirrhotic liver, for example, in a Budd-Chiari liver. So this is something very hypervascular lesion. So the surrounding lesion, surrounding liver also shows a wedge-shaped, a sharply demarcated lesion, which disappears on the later phases, on the portal venous phases. So this is a transient hepatic attenuation, or THUD, which is arterial phase prominent perfusion abnormality, which is usually subcapsular, a wedge-shaped, a very sharp demarcated lesion, and it's usually in a setting of arterioportal shunts, for example, in trauma, mass cirrhosis, inflammatory, idiopathic, or vascular compression or anomalies. So these the cystic lesions, I'll just skip, as Dr. Hira has talked about them in detail. And these just a few points about it. How do you know that it's a hypodense or a cystic lesion? You have to measure the HU. It helps us many a times, but not always. But less than 20 HU, then you are confirmed that it is mostly a cyst. So you don't project the patient again for an ultrasound to characterize it, whether it's a solid or a cystic. And another entity I would like to highlight is a TSTC, which are too small to characterize lesions on CT or MRI. That's the subcentimetric lesions, which are really too small to characterize, and we can't do anything about them, and we just have to follow it if we are suspecting any in a known primary or somebody. So another cystic lesion which is common is biliary hematoma. This is a classic appearance of it in the CT. Another important cystic lesion is the abscesses. So abscesses do have a thick wall, as we discussed on ultrasound, and we have a fluid or air. So this was a T1 weighted image, and this is a FATSAT suppressed image. And then we go to the phase images, and phase images, what we can nicely see is the edema. So I'll just skip the cystic ones here, and we'll go quickly to the solid lesions, which are the common ones.
Come to the important common lesions,
Yes.
Otherwise you will run short of time.
Yes, sir. So the case 2 was a 31-year-old female, which presented to us asymptomatic, and it was given as a heteroechoic vascular mass in left lobe. So subsequently, she was projected to a triple phase CT. The hypodense lesion is typically seen on the non-contrast scale. The arterial phase, what we can see is a peripheral discontinuous nodular enhancement, which further becomes a centripetal fill-in on the delayed scans. So this clinches the diagnosis of hemangioma. So we all know about all this, and these are like, if you see 1 to 50%, there are multiple. So just look for the other ones also. So basically, these are an endothelial line hepatic artery, and thus this nodular enhancement. So this was a companion case on MR. So this giant lesion with a scar. Now, scar is a peripheral discontinuous with progressive fill-in of the contrast. So these are the atypical hemangiomas. We'll call them giant hemangiomas, which are greater than 6 to 10 centimeter. Now, what is important is we feel that this is a scar, and it should also enhance, because hemangioma finally enhances completely. But as this is a this is usually a fibro. Small hemangiomas are also infused with the hysterectomy. Right, but it is important as a show of hemangioma. This is a rare one. So coming further, this was the flash filling hemangioma, T2, very bright lesion. So with this is what? This is third, which we just saw. So this is a arterial phase enhancement, and it's persist on the hyper enhancement. So does it look like an hemangioma because it has a peripheral nodular? No, so this is not a hemangioma because this is a continuous filling of the peripheral contrast. Similarly here, this is a rim enhancement, not a nodular discontinuous like of enhancements. So these lesions could be the mimickers. Lesions with peripheral enhancement, you think about that this is the arterial phase, they are taking up hemangioma, but this is the rim enhancement. So these are usually a malignant lesions which show. Similarly, this is a thing, and this is even showing a centripetal fill-in. So does it mean you have to see the periphery also? The periphery is losing the contrast, and this is showing a very ominous sign, which is called as common and peripheral washout sign pathology. Not has to be a malignant lesion. So another case 3, an unusual age for this lesion, but what we saw, I'm just presenting. So this was a case on the arterial phase imaging. The lesion takes up the contrast. This is a 3-year-old boy, and further portal venous phase, it retains the contrast. On the delayed phases, the scar is enhancing. If we see it closely, the scar is enhancing. And we do the MIP image. This is the characteristic feature of a radiating stellate-like appearance of an FNH. So we also did the MR imaging of the lesion. So this was a well-defined lesion with the scar, and on the portal venous phases, it is enhancing. On the arterial phase, it took up the contrast. Portal venous phase, it took up the contrast. Delayed phase, it retains the contrast, but in the hepatobiliary phase, the scar is enhancing. So this was an FNH. So FNH basically has an aberrant dystrophic artery, which imparts the central scar. Now, this scar is usually a tight proliferative response to an aberrant dystrophic artery. So on CT and MR, on the non-contrast, you can barely the lesion is barely visible to you, and it's homogeneous. On further arterial, there is a bright homogeneous enhancement, and it becomes iso on venous and delayed soon. So it becomes iso on venous and delayed. But on MR, you can appreciate the central scar, which is a T2 dried with the delayed enhancement. These are the basic characteristics of an FNH. The demographics we have talked about, they're more common in females. Okay. So now again, this is again a 35-year-old female, as we just talked about. Are all the hyperechoic lesions on ultrasound hemangiomas? So this was an incidental finding, and the hyperechoic lesion did not turn out to be a hemangioma. This MRI was done, and this is the in phase and the post phase, which rules out the intravoxal fat, and there is a hypointensity in the periphery, which suggestive of the fat containing lesion. So echogenic lesion on ultrasound is not always hemangiomas. Rarely they can be a fat containing lesion. And similarly, the T2 images, this was hyper intense on T2, but not as more not as hyperintense as a sister hemangioma. On the venous or the delayed phases, it loses out the contrast. So fat was the fat within lesions. This was came out to be the adenoma, but this was based on the demographics of a 35-year-old female. That was the first kept diagnosis. Other rare lesions, fat containing HCC, and other rarer lesions could be angiomyolipomas, and rarely FNH in the setting of diffuse hepatic steatosis in a obese patient. So this is what I want to emphasize upon, the use of hepatobiliary contrast agent to distinguish between FNH and hepatic adenomas. So FNH usually is made up of hepatocytes, so the hepatocyte specific contrast is taken up by the tumor itself, whereas in the setting of this last images, the first top row is FNH case, and the second top row is the hepatic adenoma. So in the arterial phase, both of them, venous phase, that retains contrast, the FNH, and on the hepatobiliary phase, it's brilliantly enhancing with a spoke-like, and we can even see the internal architecture on it. Whereas the adenoma loses out the contrast, and in the hepatobiliary phase, it does not retains the contrast. So teaching point of women on OCP, a diffusely enhancing mass that does not meet the criteria for FNH, and it is more heterogeneous. So the FNH, it seems to be more homogeneous rather than a adenoma, which is more heterogeneous. Both of them are arterial enhancing. So we have to think of hepatocellular adenomas, which DD may include FLC, HCC, as we'll further see. So I'll further go with the adenomas. These are the three main types pathologically, and there are slight characteristics on imaging also, which can even differentiate between these. But I think the time does not permit me to show more of these. So we'll stick to next entity. Hypervascular liver SOL with the central scar. We just saw a lesion with that. That was FNH. So is it diagnostic? The FNH has a hypervascularity and a central scar? No. So let's see. This was a 22-year-old female with an incidental mass. So this is a pre-contrast MRI with a scar, and this is the hepatic arterial phase with enhancement, with the portal venous phase losing out the contrast, and the delayed phase completely losing out the contrast. So, but the if we see the CT, we could see the calcifications. And even on the triple phase CTs, the lesion loses out the contrast. So this was FLC variant of HCC, which is an uncommon variant of hepatoma, can be FNH.
Sanyukta, you will have to finish in another 3 minutes.
Okay, sir. So this is the same population, same patient population. So it looks like FNH, but it's too heterogeneous. So we have to think of fibrolamellar HCC. Another next entity we'll talk about, this is the arterial phase hyper-enhancing lesion. But look at the enhancement. This is a rim-enhancing lesion, not a peripheral nodular. And what we can see is a capsular retraction also. Now this clinches us the diagnosis. The lesion contains some fibrotic component. And on the delayed images, this is showing a peripheral washout. So the viable tumor lies here, and the unviable or the fibrotic component lies here. And this is what the imaging characteristics show us. So these are the capsular retraction. This was came to be a intrahepatic cholangiocarcinomas. So the peripherally has the viable tumor, and the dense fibrous stroma is at the center. So we can also, this has a characteristic feature on the diffusion also, showing a targetoid appearance. This is again the viable tumor showing the diffusion. So this was a targetoid enhancement with rim arterial phase hyper enhancement on the but on the much delayed phases, it has a delayed central enhancement. Another very important component is the cirrhotic liver. How do we diagnose the HCC? So HCC has a typical pattern of enhancement. A hepatoarterial phase, it does take enhancement, but it has to be a non-rim arterial phase hyper enhancement on which washes out in a portal venous phase and which retains a cap. If it's a 2 centimeter or more arterial hyperenzyme mass in a cirrhotic liver that washes out and has a capsulitis diagnostic of HCC. So this was a case we encountered. And so T1 also shows some hyperintense areas. So these hyperintense areas can either be fat, can either be hemorrhage. So this does not drop on opposed phase images. So this was considered as a hemorrhage, and this was the lesion. So lesion is taking up some contrast in arterial phase, definitely, and is losing out the contrast. So this was a cirrhotic liver. So in the picture of a cirrhotic liver, and it's showing HCC. So we'll talk about these enhancements in detail. This looks again an exhaustive slide. I'm nearing to my end of the lecture, but I would just like to emphasize upon the enhancement patterns which helps us clinches the diagnosis. So the peripheral discontinuous becomes a very characteristic of hemangiomas. The mosaic what we can see here, the three enhancement type characteristics which are very sinister type of ring enhancement. That is a ring enhancement, which is almost always either a inflammatory pathology or cancer, metastasis, or HCC, ICC. And then we have a target enhancement that's usually a metastasis, and a mosaic enhancement, which is usually a HCC or FLHCC. What we have to differentiate between are the hypervascular lesions on these triple phase MR and CTs. These are the FNH, HCA, hypervascular degenerative nodules, HCC, FLHCC. We just talked about each of them. And the peripheral washout sign, which is very particular of the malignant lesions. So if we know the enhancement pattern of all of these rim enhancement lesions, mild diffuse, with the help of the history, with the help of the delayed or the hepatobiliary phase, we know when to take which phase, with the help of the T2 and T1 signal, with the help of the scar and the fat or the calcium content, we can make a diagnosis. So we just have to tell the clinician, I suppose, don't touch me lesions, the biopsy or the further imaging lesions, and which are the suspicious for malignancy, or you are very much sure that these are definitely a malignant lesion. So we again a bit about the LIRADS. LIRADS is usually done in a cirrhotic liver. How to manage those there is this continuum of the nodules, dysplastic nodules, low grade, high grade, early HCC and HCC. We talk about definitely probability 3, probably HCC, definitely HCC, LR5. So this is again, we have to consider the three characteristics, mainly arterial phase hyperenhancement, the size, the enhancing capsule, the non-peripheral washout, the threshold go. This is again a very
I think I'll have to interrupt and stop you because
this is my last slide. Like, okay.
Et même à supposer que mon école en étranger, mon école en français, également les lois du pays dañuy appliquer ci moom. La preuve, fi mu toll.
See, just a comment for both of you that you gave very detailed radiological description, but you have to understand that this is a surgical masterclass. So I will ask very straight, pointed questions because we don't want to encroach on Dr. Gambhir's time. Am I audible?
Yeah. Go ahead.
First question is, after doing an ultrasound, if it is a cystic or a solid lesion, when should we proceed with a CT or MRI? And if we should proceed, when should we do CT and when should we do MRI as the first investigation? See, all these are detailed radiological findings which are very good for a radiological audience. But from a clinical point of view, these are the questions which I would like. So quick answers, 1 minute answers from both Hira and you. Which lesion on ultrasound we can stop at ultrasound, and which should proceed with CT and MRI, and if yes, whether CT or whether MRI as the first investigation.
Can I also add on to that? Can you replace CT with a contrast enhanced ultrasound? Is that better? So that also, if you can either.
We just have 3 minutes. Hira.
Hello.
Yes.
Yeah, so first I'm coming to the Kapoor sir's question that in which lesions we should go further for imaging after the ultrasound, which we should stop. So I would say that in the benign lesions, specifically the patient does not have any background liver disease, patient does not have any other primary lesions, and if this lesion is solitary cystic small lesion with imperceptible wall, then we should stop. We can follow up the patient. Okay, that this is definitely confidently cyst. So for the solitary small simple cystic lesions, we do not require any further imaging. Now, if patient come with some background CLD, if patient has a lesion, solid, whether is it 2 centimeter lesion, is 5 centimeter lesion, solitary or multiple, definitely we require triple phase CT scan for those patients. Again, if patient has normal background liver and a solitary lesion, a well-defined lesion, then we can have follow-up. We do not require any further imaging for those patients. Like for example, hemangiomas, definitely we can confidently say this is hemangioma, except some metastatic disease. Definitely, patient have metastasis, they have already diagnosed primary diseases, so we require CT scan for them, or MRI if the patient few lesions which are not diagnosed
We
on
have
the.
one more minute, Sanyukta. If we have to further investigate after an ultrasound, what would you prefer? If available, contrast enhanced ultrasound, a triple phase CT, or a contrast enhanced MRI?
So in the cystic lesions?
No, whatever lesion we have seen on, let's talk of solid because cystic is a little easier. Solid
Yes.
lesion on ultrasound, we want further investigation. What is the choice further?
The MRI, as per the studies, this is more sensitive. We tend to take more dynamic phases, and the lesion characteristics can be identified more easily on MRI.
Okay, I think we will have to move on because it is 8:30, and that is why I insisted that we should leave enough time for discussion, because there are so many questions which need to be asked, but we don't have time. So maybe Dr. Saraswat, you can introduce Dr. Gambhir and we can proceed.